Tirzepatide has quickly become one of the most talked about breakthroughs in the world of metabolic health and weight management. As a novel dual action medication targeting both GIP and GLP-1 receptors, it's generating unprecedented excitement in the medical and wellness communities. With clinical trials showing dramatic results in weight loss and blood sugar control, Tirzepatide is being hailed by many as a game changer, a potential miracle drug that could redefine treatment for type 2 diabetes and obesity. Monjaro is available in Indian market. Price ranges from 3500 to 4500. Semaglutide, which is a GLP-1 agonist, is available in tablet form as Rybelsus and subcutaneous form as Wegovy. Apart from semaglutide, there are other formulations available for GLP-1 receptor agonists. You can pause the video and go through them. Tirzepatide exerts its anti-hyperglycemic effects through glucose-dependent insulin secretion, delayed gastric emptying, and suppression of plasma glucagon levels. Additionally, it improves lipid metabolism and reduces visceral adiposity. It also activates central and orexigenic pathways, thereby enhancing satiety and promoting weight loss. Incretins got their name because of their action in intestine-mediated secretion of insulin. Endogenous incretins are secreted from K cells in duodenum that secretes GIP and L cells in ileum which secretes GLP. Pharmacological principle of incretins is based on the incretin effect, which refers to the observation that plasma insulin levels are higher after oral glucose administration compared to those following IV glucose administration. Here, I would also like to add a note of caution as GIP and GLP-1 agonists will act synergistically with sulfonylurea drugs and thus may increase the risk of hypoglycemia when used together. This slide shows the mechanism of release of insulin from islet cells of pancreas. GIP and GLP receptors increase the activity of adenylate cyclase enzyme, which increases intracellular cyclic AMP and activation of downstream pathway as shown. Pathway is very much similar to that of glucose-mediated release of insulin. Only difference is protein kinase A-mediated inhibition of voltage-gated and ATP-sensitive potassium channels. Since we are here to understand the weight loss-causing effect of tirzepatide and semaglutide, I would also like to brush up the orexigenic pathway of brain. Neuropeptide Y and a Gauter-related peptide expressed in arcuate nucleus of hypothalamus acts on lateral nucleus of hypothalamus, ultimately resulting in increased food intake. GIP is a negative regulator of NPY and thus promotes satiety. Arcuate nucleus of hypothalamus has POMC neurons and CART neurons, which upon activation results in increased release of alpha melanocyte stimulating hormone that promotes satiety. Now, GLP is highly expressed in arcuate nucleus of hypothalamus and thus promotes satiety. I would also like to add GIP receptors are highly expressed in hippocampus, olfactory lobe, and cerebellum, and thus are involved in neurogenesis and memory formation. GIP and GLP-1 are protective against neuronal apoptosis and are being studied for possible effect in delaying Alzheimer's disease. Coming to the effect of GIP in lipid metabolism, GIP stimulates a lipoprotein lipase present on the surface of adipocytes and hydrolyzes lipoprotein associated triglycerides, causing release of free fatty acids which are utilized by adipocytes in lipogenesis. Thus, the anabolic effect of GIP on white adipose tissue prevents ectopic fat deposition in visceral organs, which is seen in metabolic syndrome. GLP, on the other hand, causes lipolysis. It acts indirectly by increasing sympathetic activity on adipocytes. The opposing effects of these two maintain adipocytes in healthy state and aids in maintaining higher levels of adipose tissue, which in itself is potentially anti-diabetic and anti-atherogenic. Adiponectin is also responsible for the effects of GIP and GLP-1 on hepatocytes. ESSENCE trial is an ongoing trial studying the effects of semaglutide on regression of fibrosis in metabolic dysfunction associated steatohepatitis, also known as MASH. Now, focusing on action of tirzepatide on weight loss, based on a series of comparison studies in diabetics for weight loss, tirzepatide was found to be most efficacious, followed by injectables, semaglutide, liraglutide, and so on, as mentioned. Additionally, it was noted that worsening hyperglycemia resulted in decrease in effect of GLP-1 receptor agonists on weight loss, as weight loss in diabetics was 4% in scale diabetes studies as opposed to 6% in non-diabetics. Similarly, step 2 trial in diabetics showed 6.2% reduction in weight loss as compared to 12.4% in step 1 study of non-diabetics. Finally, Surmount 2 trial revealed a similar data of 9.6% weight loss in diabetics as compared to 17.8% in Surmount 1 trial, which was conducted in non-diabetics. I would also like to add that scale trials studied effects of liraglutide 3 mg per day over 56-week period. Step trials studied the effects of semaglutide 2.4 mg per week over 68-week period, and Surmount trials studied the effect of tirzepatide 15 mg per week over 72 weeks period. All three trials thus revealed 30 to 50% lower efficacy in weight loss in diabetics. Participants of all three trials also were found to have 3 times higher reduction in fat mass as compared to lean mass. But since loss of lean mass could be potentially dangerous in older population and in patients of chronic disease, there is an ongoing research into nutritional and exercise interventions and also the effect of novel pharmacological agents such as myostatin, activin pathway inhibitors, into preserving lean mass and improving overall health in patients treated with GIP and GLP-1 agonists. This is a very concise compilation of following articles. Anyone interested in more detailed reading can refer to these articles. Follow Learning Lungs for more such updates. Thank you.